Welcome back, guys. In this video, we shall discuss about recovery trial. Recovery stands for randomized evaluation of COVID-19 therapy. It was done by Recovery Collaborative Group and it was released on June 22nd in 2020. In any trial, we discuss about a format, that is PICO principle. PICO stands for P for participants or population who are relevant patients, I for intervention or indication, the management strategy, diagnostic test or exposure that you are researching, C for comparator or control, is there a control or alternative management strategy, test or exposure, and O for outcome, what are the patient relevant consequences. So we will discuss in this format, PICO format, right? So before that, we need to know about the recovery trial setting. So recovery trial was done in UK, that included 176 NHS hospitals in the UK, and so the patients were recruited from like March 9th to June 8th, 2020. So the clinical question was in whether in hospitalized patient with SARS-CoV-2 does dexamethasone in additional to usual care compared to usual care alone will whether it reduces 28-day mortality or not. This was the clinical question. The design was unblinded, adaptive, randomized controlled trial. Following written consent from the patient or next of kin, patients were randomized to dexamethasone 6 mg once per day for 10 days and compared to the patients randomized to the usual care alone. And patients were hospitalized and were not necessarily in the intensive care, and patients were allocated using a central web-based randomization service, and they are randomized in a ratio of 2 is to 1 is to 1 is to 1, that is usual care and dexamethasone, lopinavir, ritonavir, or hydroxychloroquine and azithromycin, and respectively. And there was no blinding in this study, and analysis was by intention to treat. The Independent Data Monitoring Committee reviewed unblinded study data intervals at intervals around 2 weeks. Coming to the P, first letter of PICO, it included the inclusion criteria for the recovery trial was clinically suspected or proven SARS-CoV-2 infection, age more than 18 years, and patient were permitted to be included if pregnant or breastfeeding. And the exclusion was indication or contraindication to dexamethasone and dexamethasone unavailable in hospital at time of randomization. These were the exclusion criteria. A total of 2,104 patients were randomized to dexamethasone once per day for 10 days and compared to 4,321 patients randomized to usual care alone. Mean age was 66.1 years, and out of which 36% were female, and diabetes in 24, and heart disease in 27, and chronic lung disease in 21%. And mean age was 1.1 years older in patients allocated to dexamethasone. Otherwise, baseline characteristics were similar between the groups. Coming to the I of PICO intervention. Dexamethasone 6 mg daily for 10 days, intravenous or oral. And in case of pregnant or breastfeeding women, prednisolone 40 mg administered by mouth, or IV hydrocortisone 80 mg twice daily was administered. The C of PICO is control. The control was usual care alone. So the treatment groups were being studied are categorized into group A, B, and C. Group A consists of like no additional treatment, corticosteroid in the form of dexamethasone administered as an oral. In pregnant or breastfeeding, prednisolone was used. Lopinavir 400 mg or ritonavir 100 mg by mouth was given every 12th hourly. This arm has ceased to exist because there was no benefit demonstrated. And hydroxychloroquine was also ceased because there was no benefit at all. And azithromycin 500 mg by mouth or nasogastric or IV once daily was given for 10 days. The group B and C included, in addition to treatments, they have randomized to receive convalescent plasma or not. And group C included, if there is any evidence of progressive inflammatory state by IL-6, CRP, or ferritin, they have randomized to receive tocilizumab or not. The outcome was primary. The complaints with the treatment in the case of was 95%, and 7% of the control arm received dexamethasone. So the primary outcome was 28-day mortality, which we have discussed in our clinical question. So the age adjusted mortality was 21.6% versus 24.6%. The rate ratio was 0.83, 95% confidence interval of 0.74 to 0.92. So the rate ratio here, we can see that the rate ratio is closely related to the risk ratio and is computed as the ratio of incident rate in the dexamethasone group divided by the incident rate in the usual care group alone. The secondary outcomes were when there are pre-specified groups already been determined. So the mechanically ventilated patient 28-day mortality significantly reduced in dexamethasone 29% versus 40.7%, and patient receiving oxygen, this the the mortality was significantly reduced in the dexamethasone group, 21.5% versus 25%, and patients not receiving any respiratory support, no significant difference was seen in these patients. So the time from symptom onset to randomization influenced outcome. Dexamethasone was associated with a reduction in 28-day mortality among those patients whose symptoms were for more than 7 days, but not among those with symptoms for less than 7 days. So the length of hospital stay, the median day was 12 days versus 13 days. It's significantly reduced in the dexamethasone. And the use of ventilation also significantly reduced in the dexamethasone. And any documented new major cardiac arrhythmias was not reported during this period. Finally, the author's conclusions were dexamethasone at the dose of 6 mg per day given for 10 days reduces 28-day mortality in patients with COVID-19. The effect is best demonstrated in mechanically ventilated patients. The number needed to treat were 8, and it is also apparent in patients needing oxygen therapy. The number needed to treat were 25 patients, 25, and it does not look to be helpful in patients not requiring mechanical ventilation or oxygen therapy. It is likely more helpful if started more for like greater than 7 days after symptom onset. So coming to the strengths, the strength, it is a remarkable trial conducted rapidly in the setting of a rapidly growing global pandemic. First thing is, and the second thing is the allocation concealment was done and intention to treat analysis was done in this, and it was robust and clinically significant meaningful outcomes were seen. And in this trial, you can see there are relevant pre-specified subgroups. The sample was suitable enough for extrapolation to the global population. And the recent DEXA ARDS trial also showed a similar benefit. Coming to the weaknesses, primary outcome was only available in 95% of patients only. And there are many flaws exist with the adaptive trial design too. This trial was unblinded and usual care was not standardized at all and rapidly evolved between March and May 2020 in UK. And sample size was not set priori, nor the point for an interim analysis. It is unclear as to how patients died, and there is a little information in this preliminary report about baseline severity of illness. And so the bottom line is this large trial demonstrates a significant benefit from the administration of dexamethasone to hospitalized COVID-19 patients requiring supplemental oxygen or mechanical ventilation. So based on this trial, if I had a patient in ICU, I would give dexamethasone, and who requires oxygen or mechanical ventilation, I would administer dexamethasone 6 mg daily for 10 days. Thank you very much. And these are my references.